Hello, everyone, and thank you for joining the CDTRP Level Up webinar series. My name is Katja Loban. I'm a trainee with the CDTRP and a postdoctoral fellow at the Research Institute of the McGill University Health Center in Montreal. I'm working with Dr. Shaifali Sandel, who you probably already know. I will facilitate today's webinar. The University of Alberta hosts CDTRP, and we respectfully acknowledge that we're located on Treaty 6 territory and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I encourage you to acknowledge the land that you are on in the chat box. Today, CDTRP is excited to welcome Dr. Tennankore, who is presenting on the topic, Why Does Frailty Matter for Patients Waiting for a Kidney Transplant? But before I introduce Dr. Tennankore, we have a few housekeeping notes. Today's webinar and discussion are being recorded and will be posted on the CDTRP website and YouTube channel. During the presentation, we kindly request that you turn off your cameras and mics. Once the presentation is complete, we ask that you turn on your cameras, and if you have any questions or comments, ask the presenter directly. You may also add comments or questions in the chat box or privately message the CDTRP Q&A if you prefer to keep your questions anonymous. Now it is my pleasure to introduce Dr. Tennankore, a nephrologist and associate professor of medicine. His clinical expertise includes chronic kidney disease and home dialysis modalities. In addition to resident clinical education, he has an interest in research methodology and runs the research rotation for nephrology trainees. Dr. Tennankore is interested in studying and improving outcomes of patients after initiation of dialysis and transplantation, and he is part of national and international research initiatives in home dialysis. He's involved in clinical trials and conducts a number of prospective cohort studies in nephrology. Dr. Tennankore, it is my pleasure to turn it over to you.
Great, thanks a lot. I'm just going to take over screen sharing, and hopefully nothing will happen, so I might just ask for another sound check after this. All right, can I just double check that you're able to hear me okay?
Yes, everything's perfect.
So thank you very much. Before I start, I myself want to acknowledge that I'm speaking to you from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, and I acknowledge them as the past, present, and future caretakers of this land. I also want to acknowledge that I do have some disclosures that I have to mention. I've done some advisory and consultancy work with the companies that I have indicated. I've also gotten some investigator-initiated grants that are active right now. But importantly, none of my disclosures really are relevant to anything I'm going to be talking about today. So really, I have a couple of key objectives today. I want to chat with you about the definition and classification of frailty. I want to talk to you about how frailty impacts kidney transplant recipients and kidney transplant candidates. Then touch on an ongoing Canadian study that I'm leading here just around frailty and the kidney transplant waitlist, and then close with some discussion about future directions for research that is going to positively benefit patients. But to start, of course, the big question is, what exactly is frailty? One of the best definitions I've come across is that it's a syndrome of low reserve and reduced ability to resist against stress due to a decline across multiple body systems that leaves a person vulnerable to bad or poor health outcomes. And in a consensus of 121 geriatric specialists and healthcare workers, overall, they were able to identify 39 statements that really encompassed this entity of frailty. And I thought I'd just pick a couple of the key ones, and that is it's multi-system, it can change over time, it does lead to vulnerability, it's not the same thing as disability, and very important with respect to transplant, it can be reversed or stabilized. And we'll talk about why that's important a little bit later on in the talk. And when we sort of think about a frailty in more of a sort of overall sense, you can see that some people can be at risk for isolated changes in health systems, single system disease, as we call it, but they still may do okay despite this. They still may maintain good function. But as those impairments in body systems build up over time, you start to see that the functional reserve of patients may start to change. And then ultimately, if these changes result in permanent damage to a patient's body systems, you start to see states that may be much harder to reverse or even stabilize. But this really focuses on frailty being something that it's affecting function. But as you can see, most definitions of frailty think about it in a cumulative deficit sense. And what do I mean by that? Well, you might be frail if you have trouble with mobility or movement. You might be frail if you have troubles with cognition, things like memory, executive function, mood, maybe social vulnerability, where you don't have a great social support network, which makes it harder for you to deal with medical stress. Of course, we know that chronic diseases or chronic illnesses can put somebody at risk of poor health outcomes, low nutrition, and exhaustion. And so frailty is really informed by all of these different constructs. And that provides this sort of idea that one thing being affected in of itself may not actually lead to somebody being frail. So this is good in terms of a definition of what frailty is, but I really want to emphasize what it's not. And if you sort of Google the definition of frailty, you'll come up with this definition. It's the condition of being weak and delicate, or it's weakness in character or morals. And obviously that's not what I'm going to be talking about today. But I want to emphasize that understanding these definitions that might be out there is very important, because in a qualitative study, all of which was done among patients, some participants did feel that the term frail had negative connotations. And you can understand why when you might be searching this and you come up with these types of definitions. And just to add a couple of quotes from this qualitative study, one patient said, "The whole attitude is one of defeat as soon as you see that word." Another patient said, "Just because I can't walk as fast as I did 2 years ago, does that mean I'm frail? That seems unfair, really." And so we do have to keep these ideas in mind when thinking about the terminology and the way that we use these phrases and think about and study them. And I think this is going to be something that's going to be even more important going into the future. So I've talked to you a little bit about the definition of what it is and to some part the definition of what it's not. How do we then go on to actually measure frailty? Because a definition is only as good as the words in it. How can you actually quantify that? Well, by far the approach that holds the most validity is something called the Fried frailty phenotype. Now, this was first described by Linda Fried in 2001, and it's really composed of questions or objective findings across 5 key areas. Slowness or slow walking speed is based on different cutoffs based on height and male versus female sex in terms of a distance that one is able to walk. Weakness is assessed using a dynamometer, which captures how good one's grip strength is. Weight loss is typically captured through a question and some measurement of weight over the prior year. Exhaustion is a question, and then low activity is based on a more robust questionnaire talking about how active someone is. And if somebody has any 3 of these features based on those certain cutoffs, then they would be classified or characterized, I should say, as being frail. So that was the most commonly used tool to assess frailty. The second most commonly used one is something called the Frailty Index. A Frailty Index is made up of 30 to sometimes as high as 70 conditions, importantly, that are across multiple different areas. And those include function, cognition, medical illness, mobility, similar to that chart that I showed you earlier on. Now, if you have that condition, it's scored as being present. If you don't, it's scored as being absent. And the Frailty Index is just a ratio of how many of those conditions one has over the total number of conditions in that Frailty Index itself. Now, it's very important to appreciate that these are often condition specific. And what I mean by that is that you can't say take a Frailty Index that was developed in a liver transplant population and apply it to a group of community dwelling, otherwise healthy older adults. You need to develop the Frailty Index in the population and for the population. And when you graph out these Frailty Index scores, what you see is this gamma distribution. And what we mean by that is that most individuals will, have a frailty index that's not all that high, meaning that they're doing very well. They're not considered frail. But then there's a smaller number of patients that might have lots of these individual deficits, but there's usually a peak score. And that peak score really reflects that as we build all of these deficits, we may reach a point where survival is actually impacted, and it's hard to have a score higher than that at that point. Finally, the last one I'm going to talk about in terms of a measure is something called the clinical frailty scale. And this is something that's close to me in the sense that it was created by one of my mentors here in Dalhousie. And it's actually a clinical impression of frailty severity that's based on function. And as you can see, there are a number of different images and a description indicating what that sort of image means. And then clinicians are able to grade or rate the severity of frailty in an individual that they're seeing in front of them. And very interestingly, this tool has actually been converted so that patients can actually grade themselves and caregivers can grade patients as well. And so it's becoming even more robust, and it's a tool that's being able to be used in a variety of different populations. The big problem with this tool, of course, is that it's subjective. You're looking at someone and you're basing it on your knowledge of that patient and providing them with a score, but there's no real objective measures that are absolutely have to be done as part of it. It's just your own impression of that frailty severity. So those are just 3 tools, but I want to highlight, we're not going to go through all of these, but there are a broad number of tools that have been looked at in the transplant population and the pre-transplant population, each with their own strengths and weaknesses. And I just wanted to go back to the 3 tools that I talked about just to go over some of those differences. So that Fried phenotype that I talked about, that was the first one, is more of an on-off switch. You're either frail or you're not frail. And in a way, it's the simplest to understand for both practitioners and patients. The flip side is that I'm not sure it has a good construct validity. And what I mean by that is that we think of frailty as being something that's a continuum, not something that's just an on-off switch. So this may not be capturing that very well. The frailty index is a continuum. You can get a number of different scores, but it's a little harder to capture, especially if you're looking at collecting 30 variables. And it's a little bit harder to understand, what does it mean if my score is a 0.1 and someone's is a 0.2 and another's is a 0.35, a little bit more difficult. And then, the clinical frailty scale does actually have some continuous nature to it. So maybe a little bit more, biologically, or have a little bit more construct validity. It's a little bit easier to understand, but like I said before, it's more of a subjective tool. So we always worry when we don't have objective measures, how good is that subjective tool really accurately capturing what we want it to? So acknowledging that they capture different information, how do they actually agree with each other? Well, this is a Venn diagram from a study that we're currently doing, showing how the measures overlap with each other. And what you can see here in the middle is that there are a group of individuals in this particular study who were identified as being frail, irrespective of which of the tools they used. But you can see there are large areas of non-overlap here, suggesting that maybe each of these tools is capturing only a small aspect of this underlying syndrome of frailty. And so the big take homes from this section are that there are a number of different frailty assessment tools, each measuring maybe a different aspect of this syndrome. And you could make the argument that because there's only a little bit of overlap, more is better. But I think you have to consider whenever doing more tests and more tools, burnout both with patients and with practitioners, and whether you have the resources to collect all of that information. So with that, I want to move on to the impact of frailty on a number of different health outcomes. And when you look at the general population, many studies suggest that the higher level of frailty severity you have, the more at risk you are of things like mortality, dying, that is, being hospitalized, experiencing a fracture, maybe being admitted to a nursing home facility, or using more and more health resources. So I really just wanted to focus in a couple of slides on those outcomes that are most important to kidney transplantation. And this was a study that we did back in 2015 among a little under about 400 individuals who initiated chronic dialysis. And what we did is we collected their frailty severity scores at the time that they started on dialysis, using that clinical frailty scale that I showed you earlier. And we found that this clinician gestalt or impression was actually associated with a progressively lower chance of surviving to the point of transplant, such that those who had those really high scores of 6 or 7, none of them actually got to the point that they were able to get a transplant. They all either remained on dialysis or died while receiving dialysis. Now, this was a one-time measure of frailty, and it was really looking more at access to transplantation. So what about those who are frail who actually do get a transplant? Well, most of the data relies on that freed phenotype that I showed you, that on-off switch. And it comes out of really good work done by Mara McAdams DeMarco and Dori Segev. And what they found in their initial study of around 540 patients was that frailty was in fact associated with a higher chance of dying after transplant. And this persisted even when they looked at all types of characteristics of patients. And you can see that the signal seemed to be strongest kind of at that 5-year mark, where there are differences in that proportion or percentage of patients who were alive who were not frail versus those who were frail. But Dr. McAdams DeMarco also showed that frailty was associated with other important health outcomes. It's not just all about survival. And what she showed was that the chance of being re-hospitalized after being discharged from that first hospitalization where one would receive their kidney transplant was much higher in those who were frail versus those who are not. But we often hear this term, well, frailty is the same thing as aging. You can see that in this particular study, it was not, in that those who were younger and frail were at the same risk of that early rehospitalization compared with those who were older and frail. So it really had nothing to do with chronological age, but this actual biological measure of frailty. I really don't want to go through an extensive talk about all the different outcomes, but we know that among individuals who meet that kind of criteria for frailty, it can be associated with things like more depressive symptoms, a longer hospital stay after transplantation, delayed function of the transplant kidney, and in the short and medium term, it's been shown that those who are frail are less tolerant of immunosuppressive medications and may have to stop them because of things like infection and other complications, and may have some memory impairment occurring after transplant as well. So of course, what I often hear is, okay, this is great, but this is kind of what we expect. Who cares? We know this. We already have other markers that tell us that this is in fact the case. And the first thing I often hear is, well, frailty is just the same thing as getting old. So what I would say to this is false. Frailty, we know, is very common, even in younger patients who are both on dialysis and after transplantation. I sometimes hear that, well, frailty only happens when someone has all kinds of other medical health illnesses. But remember, I showed you that there are multiple different things that can kind of feed into this syndrome of frailty. So I would say this is false. And it's been shown that one can be very frail with very few illnesses. One can have very many illnesses and not be frail at all. And then the last thing I hear is, we don't really need a tool to tell us this. We're doctors, we have lots of training. We can just guess what a patient's frailty level is. And I would say that this is false as well. In fact, in one study, when they tested how well doctors were able to assess whether somebody was frail by evaluating and looking at them, and then also tested a more objective tool, what they found is that only a little under half of the doctors were able to assess somebody as being frail who actually was. And an even smaller number of patients were able to assess whether they in fact were frail compared to those more objective measurement type tools. So the big take home from this section is that it's pretty clear that frailty has a pretty big impact on health outcomes after kidney transplantation. And we know that this can occur with or without other health conditions, and it's irrespective of one's chronological age. But of course, the big question is there a population that's missing? We showed that dialysis population and their access to transplant. We showed that post-transplant population. Well, of course, the one that I'm the most interested in is, how does frailty in fact affect those who are waiting for a transplant or who are being evaluated for a transplant? And again, when we think about outcomes for those on the wait list, most of the data that we have available to us comes out of Dr. McAdams DeMarco from the United States. And in one study, she looked at a little under 2,000 individuals who were waitlisted dialysis candidates. So in other words, activated and ready to potentially receive a kidney transplant, and assessed how many of them were frail. And she found a little under 20% were. And overall in the study, about 200 patients, unfortunately, were not able to survive that period of waiting to actually make it to the time of getting a transplant. And those who were frail were about twice as likely to die before getting that kidney transplant. So you may say, okay, well, how does this impact care? Is this important? Well, it's actually been shown that if you come from a center or an institution that always assesses frailty, that measures it and quantifies it during that wait list, your center may have a lower rate of transplant, but they also have a lower rate of patients dying before transplant. But even more valuable, I think, to patients is that centers that always assess frailty at the time of transplant may actually have an improvement in how long that transplanted kidney will last. You may ask yourself, okay, well, why is this? Well, it might be just simply recognizing it by measuring it leads to changes in the way that we deliver care, maybe some individualized support, interventions, maybe following patients a bit more closely that then protects them against longer term harm. So this information is really good, but it's all based in the United States. And we know that Canada is not the same thing as the United States. We'd be happy to know that individuals on dialysis and after transplant actually generally do better in Canada compared to the US. We know that those who are on the waiting list live longer in Canada. And as I mentioned, these studies are all US based. I know of one other study taking part in Toronto that's doing something similar to what I've been doing over the last several years. But to my knowledge, these are some of the only few studies that are looking at this in a systematic way. So that brings me to talk a little bit about the study that we're currently conducting. And you can see that this study has been going on for about the last 8 years. Unfortunately, it was supposed to be done much earlier, but because of the pandemic and shutdown of research services, there was a little bit of a pause in there. But really what we're interested in this study is looking at those who are being worked up or listed for transplant and their outcomes while they're waiting for a transplant kidney. You can see that we have a pretty broad group of sites that are participating from east to as far west as we were able to go, at least for the purposes of this study. We are collecting different types of frailty assessments. So that on-off switch or that free phenotype, a frailty index, which I talked about, and then that clinician impression tool, that clinical frailty scale in all of these patients that we're able to recruit. The main purpose of this study that we're doing is to look at how frailty affects those who are waiting for a kidney transplant. And we're interested in, do they survive and are they able to get that kidney? We're also interested in whether they have to be taken off the waiting list because they develop another health condition that prevents them from getting the kidney. And we're looking at a number of different outcomes that I've listed there as well. Now, remember when I mentioned that if you're going to look at a frailty index, it has to be specific to whatever population you're looking at. So we did just that. We generated a waitlist specific frailty index. I'm not going to go through all of these items, but I really want to emphasize that this index looks at other aspects of frailty, including things like social or cognitive function, one's functional ability, how well they can move, and medical illnesses as well. And so in all patients, we're capturing and measuring this particular score in addition to the other ones. Now, as you can tell, the study is not yet completed, but I thought I'd talk a little bit about some of the results that we've shown so far. And what's nice is that these are all Canadian results. So we've analyzed about 500 individuals so far to look at these outcomes. And you can see that the age of these individuals is around 54, and more of them are male versus female. And as expected, the majority of them are receiving hemodialysis. Now, what we found in this study in our preliminary look was about 16% of individuals in the study were frail using that freed phenotype. And some of the things to point out, and we can look here in these red bars, these are sort of looking at those who are frail with red, those who are pre-frail, kind of in an in-between level between being well and not. And you can see that amongst those who were above the age of 65, there were more individuals who were frail versus those who were younger than 65. If we look at dialysis, we can see that there were more individuals who were frail who had been on dialysis for more than a year. And last but not least, we can see that there were really no differences between those who were on hemodialysis or peritoneal dialysis, but those who were not yet started on dialysis tended to be the least frail individuals of the group. Moving on to the other two tools that we were looking at, you can see that both that frailty index and that clinical frailty scale followed that same kind of visual curve pattern. And if we were to use a cut point that has been reported in the literature, almost 40% of individuals were frail based on that frailty index, but only 15% based on that clinical frailty scale. So 3 different tools, all again measuring maybe different aspects of the same condition. And I want to emphasize that this study is not yet done, and I'll highlight you to this red box, but you can see that really each of these tools seem to have an association with that outcome that we were looking at. So the chance of one passing away before, getting to the point of transplant or being permanently taken off that list. And it's the same level. So just to simplify this a little bit, those who were frail were twice as likely to die or get taken off the list because of a permanent illness before they actually were able to get that kidney transplant. So, lots of information. The big question, of course, now is, okay, how do we actually take all of this information and put it into decision-making when we're actually evaluating somebody in front of us, or when we're having a shared sort of information decision between patients and practitioners? So the first thing I would say is that if you want to know, you have to measure it. And right now, capturing this syndrome of frailty is not actually routinely done for the waitlist. There are some sites that do look at things like functional status or functional capacity, and maybe with one question, but they're not looking at it in the same level of detail. And so I feel quite strongly, and we wrote this in a review article not that long ago, the frailty should ideally be measured in any individual who has kidney disease, especially those who may have kidney disease of a higher grade or severity. You should probably think about doing it in those on hemodialysis, even those who are receiving home dialysis and who have later stage kidney disease. And then you should consider some screening measure of frailty as part of that workup for a kidney transplant. So first thing is that you want to measure it. But then the next question I get is there a tipping point? In other words, should those who have a very severe level of frailty be eligible for transplant? And one of the concerns that has often been looked at in the literature is that if you're very frail, it's possible you might be at too high risk for getting a transplant surgery or being on immunosuppression. And it's possible that the chance that you might benefit from getting a transplant is lower than somebody who is otherwise healthy. And when we look at those conditions that we often think may be too high risk for somebody being well enough to get a transplant, things like dementia, maybe multi-system disease, or maybe a cancer that's active, we know that someone who had a severe level of frailty might fall into a similar range as these conditions. And so, of course, the big question is, okay, well, if someone is frail during their workup, should they not be able to get a transplant? And my short answer to that is absolutely no. And the reason why is because unlike these other conditions, frailty can change over time. And one of the things that can change one's frailty the most is transplant itself. And so this was really nicely shown, again, in some work out of the United States. And what they looked at is how frailty changed over time in those at the time of kidney transplant, 1 month after, 2 months after, and then 3 months after. And what you can see highlighted in these dark red bars is, yes, there was sort of an early increase in the number of individuals who became more frail very early after transplant. But then as time went on, most individuals got less frail, suggesting that transplant might have been responsible for restoring some of that function, some of that deficit accumulation that had built up while they were on dialysis. So it's pretty clear to me that frailty can change over time. And I didn't show you these slides, but I think it's also important to note that among those individuals who were frail when they were looked at the time of that waitlist assessment and then still frail at the same level at the time they were transplanted, they actually seem to do okay after transplant. Among those who were frail at the waitlist assessment but then got better, they did very well. And those who were frail but got worse, they tended to maybe do the worst in terms of their overall health after transplant. And so I think this dynamic nature of frailty needs to really be considered before using this as a tool to guide decisions. So the big take-home points from this section are that it's pretty clear that frailty is strongly associated with poor health outcomes for waitlisted patients. Transplant recipients who are coming from centers that capture frailty seem to have better health outcomes. Frailty should be measured, I feel, in a lot of different situations, but I don't think we're at a point at all with the data that's there to deny patients access to transplant just because of a one-time measure. Instead, we should use this information and think about ways to improve their health, knowing that they may be at more risk after transplantation. And very importantly, changes over time may be more important. So everything I've talked about so far is clinical, and the literature would support that we should be measuring frailty regularly. But what do patients think about this? And I think that's something that we often forget to ask. Well, one of the more interesting studies that I came across was a survey of patients asking them about their knowledge and needs with respect to this syndrome of frailty. There were a little under 30 patients with a mean age of around 75 years. The patients did feel that there was a psychological component to frailty, and some of them were a bit skeptical of this syndrome. I gave you a couple of those earlier quotes. And those who were frail wanted to know, most importantly, okay, you've told me that I might be frail, but how can I treat this, prevent this? How can I improve my health? And they wanted to discuss that with the doctors. And just to add a couple of quotes to this, one patient said, I want to know, what do you recommend to mitigate some of the frailty and maybe get less frail or more healthy? Or we want to know what's going on and how to treat it. And we're not afraid to hear these words. We get more upset that you didn't tell us. So that leads me to the last section of this talk, and that is, how can we actually intervene to help those who are frail, to better improve their health both before and potentially after as well. Now, I'm going to focus on the before just because it is the main subject area of this talk. And this brings me to this idea of prehabilitation. And we think about prehabilitation as improving the function of an individual before a surgical procedure. And in this case, of course, we're interested in kidney transplantation as being that surgical procedure. And again, going back to my colleague in the United States, Dr. McAdams DeMarco did study this in a trial where she took candidates who were active on the wait list, and then she gave them a physical activity intervention. And this was an individualized, pretty resource intensive, but individualized activity regimen led by a physiotherapist, including things like supervised activities, weights, and aerobic exercise, as well as a home-based exercise program. Now, I'm just going to go over one small section of this study. One of the only difficult parts about it is that not a lot of individuals are keen or able to participate. So while there are 190 people who might have been approached, only about 24 were enrolled. And 18 of them ended up participating in this program. But what they found, and this is really highlighted by this green bar here, is after about 2 months of this prehabilitation, those individuals actually exhibited more degree of physical activity compared to their counterparts, which was really, really good to see. And it suggested that this individualized program was able to make them stronger and physically better. Now, this is an early study, but what I thought was kind of interesting, even though the number of patients was only very small, there seemed to be about a 50% drop in the length of hospital stay for that transplant for those few individuals who were evaluated when comparing those who were on the program versus those who are not. So this suggests not only did patients find this beneficial and were more active, they may actually be getting a health benefit as a result of this. Now, surprisingly, at this point, we don't actually have a lot of studies that are telling us that we can, move the needle when it comes to frailty yet. But I am excited to see that there are a number of studies that are underway. This is just a list of some titles of studies that are coming down the pipeline that are really looking at this idea or notion of prehabilitation to get people stronger. And I think what's really sort of valuable that I feel is that these trials are not just opportunities to improve outcomes, but to address something that patients themselves felt was very important, as we saw in that survey study. That is, how can we make me better so that I might be potentially better able to face a transplant and to do better after transplant as well. So hopefully in the last 30 minutes, I was able to sort of summarize that frailty is very common among those who are waiting for a transplant, that it can be measured in many different ways, and we know that it's associated with poor health outcomes. Very importantly, that it should not be, in my mind, considered a permanent contraindication or barrier to transplant, especially among those who are getting better or staying the same. Rather, an opportunity to think about how can we make this experience, this health, this outcome of this individual better, both before transplant and after. And I'm very optimistic that future studies are really looking at this with prehabilitation measures. So thank you very much for this great opportunity. I have a number of references, as you can see, and yeah, I'm happy to take any questions at this point.
Great. Thank you so much, Dr. Tennankore. The floor is open to questions. You can either raise your hand or you can type the question in the chat box. I don't see any raised hands. Well, can I start with a question, perhaps myself?
Sure. It does look like there's one.
There was one.
I think.
Sorry, I'm just going to change the view to the gallery. Oh yes, Sandra, please go ahead.
Yeah, hi, great presentation. My question is, you talked mostly about liver, kidney, but is the frailty still the same within liver? And is frailty something that can, I'm talking more about post. It happens before, obviously, right? Especially with liver and kidney, but post we also have it as well. So I guess I got two questions. Is it similar to for liver recipients, and does frailty change over time?
So fantastic questions, first I'll say. So, you know, being a nephrologist myself, of course, this talk was focused on kidney transplant, but what I will say is that across all areas of transplant, so liver, heart, and lung, there is data to suggest that, again, those who are frail, if you use a tool to capture it, are most at risk of these poor health outcomes, both before transplant and after transplant. But I think one of the things we have to really, think hard about is that a lot of patients who are getting transplanted for, liver failure or for heart failure or something of that nature, that they're going to be very unwell and they're going to have a buildup of these deficits right before the point that they get their transplant. And it's the transplant itself that's going to kind of reverse this, it's going to change it, it's going to improve their health. And so again, this is why I really emphasize this idea about not treating this like a barrier to transplant. We should instead treat it as an opportunity to think about, okay, we know that this is something that might put them at risk. So how can we make them stronger beforehand? How can we get them through a transplant so that they do well after the fact? And I think importantly, how can we actually support them after transplant? So to your point about changing over time, in a perfect world, if you were to say, okay, how would I use this information to help me? I would say if I knew that somebody was frail and going into a transplant, I might want to, more closely monitor them after transplant, maybe have, more frequent visits, maybe watch them for changes in their cognition or memory, maybe get them supports, maybe think about things like not putting them on too many medications were not indicated, of course, if they need them, they need them. And thinking a little bit about strategies to even individualize how we give them immune lowering medications too. We're learning more and more that not everybody needs the exact same dose of immunosuppression after they get a transplant. And, it's possible that those who are frail maybe need a little less and a little bit more close monitoring. So, to go back to your question, yes, absolutely. We see this across the spectrum of transplant. And I think in all cases, I would feel that my approach would be the same.
Thank you. Thank you. We have a question in the chat box. Do you know if frailty is correlated with obesity?
That question. So it's a great question. So a couple of points to that. So the first one is that, when we think about the criteria that define frailty, one of the biggest ones is unintentional weight loss. So we often sort of view frailty as being associated more with malnutrition or weight loss as opposed to with obesity. But we have to be careful because obesity and a robust or a good BMI, we know aren't the same thing. And there are probably a lot of individuals who might be carrying weight, might be obese, who still might be vulnerable for health outcomes. And so to me, it depends a little on how you're calculating or how you're looking at the tool. If we think about frailty as being something that is potentially affected by cognition or mental status changes, social function, none of those things are going to be any different for somebody, whether they're obese or not. And so an obese person can still very much be frail, even if they're not losing weight, that one criteria in that one tool.
Mm-hmm. And in relation to the transplant, how do you, in relation specifically to the transplant, sorry, Robert, could you possibly clarify what you mean about the transplant? Is that still in relation to obesity?
Just looking if I can find the Q&A question.
Yeah.
Is this what about retransplant? Is that what the question is, you mean?
Yeah.
That's probably what about retransplant, as in like after one transplant has failed, what about the second transplant? I assume that's what that means. I don't think it's been looked at yet, very robustly in retransplant, and that's in part because, if we think about the program that Mara has done in the United States, that's kind of only started in around 2015. So there probably hasn't been a great window or time to look at retransplant. But again, I suspect that you have to be a little bit careful about when you're going to measure that kind of frailty measure in relation to that retransplant. And unless you're tracking it over time and people who have received their first transplant, which may be harder to do as they're 1, 2, 3, 4 years out, it's possible you might miss what level of frailty they have before that second or even third or beyond transplant. But it's a good question. I think it's an area worth studying.
Mm-hmm. And we have a question raised here. Would you like to ask your question?
Yeah, just a quick question in terms of responsibility on the sort of patient side as well. So if someone, so your argument is, we could help frail patients become, I'm going to say, less frail. So some of it's maybe by choice. Does a patient have a responsibility? Again, transplant organs are in short supply. So does a patient have a responsibility to actually deal with that so that they are, I guess, at their best? So because I think patients also have a responsibility to make sure that they put themselves in a position to impact outcomes. And so do you look at that at all in terms of a patient's responsibility to be part of that?
Yeah, I think it's a fantastic point. I mean, we think about any time that someone's going to get transplanted, to your point, there is a responsibility that the patient's going to have, taking medications, keeping it in as good health as possible. I guess what I would say is that when you look at frailty, some of the determinants of it are things that might not be, under a patient's control. Those aren't things that they might be able to help or change or modify. Some of them might be, being more physically active, trying one's best to be physically active. Again, that could be limited by other health problems, but, sort of meeting halfway or trying to be more active, trying to sort of keep fit, trying to maintain muscle strength. We often talk about, as part of the transplant process, the importance of a psychology assessment in some situations to make sure one's social, network at home is good, that they're going to be okay to continue to take medication, that they're not going to sort of be under a lot of stress and maybe stop those pills. It's pretty clear that one's social function determines how frail they are too. So I think there are opportunities for sure for patients to kind of address some of those things mutually with the doctor or with the practitioner that's looking after them. But we also have to understand some of the conditions can't be things that patients are easily able to fix. But great question.
Thank you. Are there any other questions?
We'll see
I
one.
just wanted to add to that, if you don't mind. So I'm a theme 5 co-lead on with CDTRP, and we also have the exercise hub underneath there. And so a lot of work has been done by Sunita Mahtar and Janice, not Janice, sorry. I forget her name right now. I don't just having a moment, but in Montreal, sorry, I don't know what it's medications, about the importance of exercise pre and post transplant. But we need to start having an emphasis on that. Like, I'm 25 years past, right? But I now have chronic kidney disease and stuff. And so, like, it's fair for like Rick to say you have to do stuff, but when you got fluid retention and you're not feeling well. And I also think prednisone too has a weakness too, like where you're physically weak, where you don't have muscles and stuff, which is also caused by prednisone use. Now, mine wasn't due to my transplant because they were smart enough to take me off it, but I needed it for Crohn's, right? So there's other underlying things. But I think as nephrologists and liver specialists and hearts and lung doctors go forward, that making that exercise important pre and post, the lung program does it really good, but focusing on that and putting it on the patient and having facilities to have that done and consider it like it should be part of the transplant program, and it should be covered by our government's healthcare plans, right? So something I've been trying to advocate for.
And I would say continue to advocate for that. I mean, that would be fantastic if we had those resources here to do that. One of the things I will also add to that is that, again, physical exercise has a lot of benefits. It's not just about physical health. It actually might improve mental health and mental function as well. But we do have to remember that, I view frailty as something that goes beyond just simply physical activity, mobility, and function. And so I won't mention the colleague because I know they're kind of in the position of submitting something to look at this, but their interest is on a multimodal type intervention or treatment where they might address the physical function, they might address the memory and the cognitive function, they might address the social function, depending on what might be determining that frailty score or frailty level, because we know it's very different. If we say that there's 30 items that can make one frail, then there's 30 different possibilities of things that could be treated or managed differently from one person to another. So, I agree. I feel like exercise sometimes it feels like a no-brainer when it can be done, and it can be done in a way that's safe to patients. So I applaud the work that's already being done in this area, and I think we want to think about going beyond that as well.
Yes, absolutely. Thank you. And we have another raised hand.
Just to follow up on that, one of the challenges I always found in getting on the wait list, so it's a real challenge to get onto the wait list, then it's a challenge to be prioritized. So what happens is you start exercising, you try and stay, and suddenly you're no longer an urgent case, because a lot of the transplant decisions are based on urgency, not necessarily on other criteria. So I find that it was a tough journey. I'll tell you that much. And I think that it's because we have these various factors or variables that play into the who gets to be 1A or 2 or whatever it is. And so I think it's hard to figure out. So if you're going to start exercising, which is effectively what I did, as much as you can, when you're ill, your heart's getting worse and worse. And so you try and do that. You're trying to stay out of the hospital because, hey, you may get sick, So all these things are happening. So when you do that, though, you also kind of push yourself down the line in a way, because the urgent patients tend to fly up to the top. And so it's a complex set of criteria. And so
it is. And one of the comments that someone just sort of mentioned to me offline was, well, should programs put in sort of a measure that says that if you're frail, you maybe move up on the wait list, so you're going to be prioritized. These are tough decisions, are complex questions for sure, and it's hard to say what exactly the right answer is. I think that it's clear to me that that sort of and you're not saying this by any means, but if you are unwell while you're waiting, you're still very much at risk. So I think as much as being more active or strengthening yourself may lower your sort of acuity of health, which may change I don't think for kidney, it usually works like this. It may be different for liver, for instance, but it may change your prioritization or your priority on the list. It is still going to be something that's better for you overall than, putting yourself at risk by not doing anything and waiting to, and I'm not saying you're saying that, don't get me wrong, but I see that it is a very complicated decision. And I know certainly for liver transplant there, and I don't know liver transplant as well, the area, but there are scores or scoring systems that are based on how severe your condition is that bring you to the top or to the lower part of the list. Very often, those scores are based on, conditions that put people at critical poor health. And so, it has to kind of be done that way. But those who are being active are probably improving their health or doing it in a beneficial way. For kidney, we think a lot about, waiting time as being one of the bigger determinants, of course, blood group. There's lots of different factors that do come into play. But we do know that waiting time is maybe a determinant of who's more or less frail. We kind of are showing that with how long somebody's on dialysis. So eventually there may be a score or something like that that's developed out of all of this work that might help us, practice better. Of course, very easy to say, but the simplest solution would be to have a lot more available kidneys, which is not really something that we're able to do yet. But no, your point is very well taken.
Mm-hmm. Thank you. I have a very, very small question. As a qualitative researcher, I'm very interested in that subjective component that you spoke about at length at the very beginning, and how I guess imperfect all of the measurement tools are in terms of capturing the totality of that experience. Have you looked at some of the cases where the patient's assessment of their frailty is not necessarily in agreement with the clinical assessment of their frailty?
So I myself haven't looked at it, but I kind of touched on this, but there's a couple of investigators here at Dalhousie. One of them is Ken Rockwood and Olga Theo. And Olga created something called the sort of patient clinical frailty scale. And it's very similar to what I showed you with those images, but instead it's just pictures, and it's pictures with those same images for function, for there's another set of pictures for mobility, for things like bladder function, vision, and hearing, whereby patients can self-rate where they are on that scale, and caregivers of patients, because Dr. Theo and Dr. Rockwood do deal with an older population where there may be a lot of caregivers involved. Caregivers can also rate the patients that they're caring for. So there are studies looking at, again, empowering patients, to a point that was made earlier, to sort of capture this and measure it and be aware of it as a way of complementing what we do as physicians and practitioners. And generally speaking, I would say a lot of patients would view themselves as being better than what some of these scores the physicians might sort of identify or scoring them as. And I'm not surprised about that. I'll sometimes go into the dialysis unit, and I might walk in there and I see somebody, lying on a dialysis chair connected to the machine. And, they may look, according to my eyes, as being more frail than they actually are, and then suddenly you see them on the street and they're walking down the street and, wearing a jacket and walking right beside you. So I do think there's always danger with these subjective impressions. I think we're not always right, both the physicians, other practitioners, and even patients. And so it does provide some credence to the idea of having objective tools that are really going to characterize us a little bit better.
Thank you. And we do have a comment in the box saying some factors used by doctors do not score certain diseases to reflect how sick some people really are.
Absolutely. I mean, you take a health condition, we often look at someone's health profile and, they have, say, a condition like diabetes. And, somebody who has diabetes where their control is very good and maybe aren't on a lot of treatments is very different than, say, somebody who has diabetes that has had lots of end organ complications and maybe vision problems, and their sugars aren't well controlled and they're being in and out of the emergency department. So, just having a condition listed on a chart doesn't tell you about that severity. It's a very good point. And I think one of the advantages of tools like this is we really can grade or try to capture that severity a little bit better. Of course, the hope is to then look at how it might change over time. And I think a lot of the studies that we're going to be looking at now are going to be looking at not just how can we fix this? How can we make it better? But how is this going to change over time? And really, what does that mean for patients as well?
Great. Well, thank you so much, Dr. Tennankore. And thank you to everyone for your questions and comments. If anyone has additional comments or questions, you're more than welcome to contact Dr. Tennankore directly or contact Manuel. A reminder that CDTRP's webinar continues next week, as we will host Dr. Tandon, who will present on digital exercise and nutrition. And don't forget that you can register at cdtrp.ca. Thank you, everyone, and have a wonderful day.
Thank you very much. Take care.
Yeah. Thank you. Bye-bye.